Thank you very much indeed. Right. I should start then. Thank you. Good morning, everybody, and welcome to today's health overview meeting. Before we start, I need to inform you this meeting has been live streamed and recorded. Please note that all remote participants are muted at the outset of the meeting, and you are only able to speak at the invitation of the chair. Please raise your virtual hand if you wish to speak, and then only unmute when the chair invites you to make a contribution. We do have a few more people today online because of the weather, and unfortunately there's an illness that is prevailing around us all, so we will proceed. My name's Jeff Elder. I am the chair of this committee. I'd like to go around and everybody to introduce themselves.
Good morning. Sophie Foster, overview and scrutiny officer. I'm Rachel Robinson, exec director, health wellbeing prevention director.
Good morning. I'm Rafael Rochi Chair. I'm the clinical quality lead for the ICB.
Good morning. I'm Jackie Robinson. I'm senior commissioner lead for integrated.
Morning, Paul Bowles. I'm head of operations for Shropshire Health and Regional Care Group, and that's part of the Midlands Partnership Foundation Trust that covers the Shropshire Health and Regional Geography.
Morning, I'm Marilyn Davis, Community Mental Health Transformation Lead for Midlands Partnership Foundation Trust, Shropshire Care Group.
I am Fred Parrish. I'm service manager for community mental health services in Shropshire. Extreme mental illness and physical health, and we're sleepers as part of OPFT.
Yep. Heather?
Oh, sorry. I'm just trying to juggle with my screen because it's like. I'm a council headship from Shirehall Work and a long time member of this house.
Really about to councillor for the meal, and lived in show portfolio of it for health and care.
Thank you very much. How's it going to turn back?
Yeah, good morning. Edward Towers, Shropshire Councillor for Webb, Rural and Wicks.
Thank you, Malik. Councillor for Witches North, and I chair the People's Scrutiny Committee.
And Councillor Jeff Anderson, I represent Health.
Thank you, Jeff.
Councillor Hilary Love for Church Stratton and Craven Arms.
Thank you.
Councillor Red Potter, Councillor for Leighton.
Councillor Pam Mosley, Councillor for Hogwarts and Shrewsbury.
Councillor Kevin Pardy for Sundawn, a member of the People's Scrutiny Group.
Thank you. And of course, we've got people on screen. Do you want to introduce yourself, or are you okay?
Hi everyone, I'm Gordon Coshane, Public Health Consultant working with Rachel Robinson, and I'm chair of the Shropshire Suicide Prevention Action Group.
Thank you.
Gerald Aiken, I'm an elected member for Woodchurch.
Thank you, Gerald.
Let's go next. Laura Tyler, Assistant Director for Joint Commissioning.
Samantha Cutts, Mental Health Commissioner for Shropshire Council.
Thank you. Tom Dodds.
And I'm Tom Dodds. I'm the Council Scrutiny Manager, and I'm keeping my bugs at home.
Yeah. Thank you, everyone, and a warm welcome to you. I hope you feel better, Tom, because you do sound a bit deeper than normal. Okay. Apologies. We'll start the meeting then. Item 1, apologies for absence. Done.
Apologies being received from Councillor Nick Barsley.
Indeed. Item 2, disclosable interests. If anybody has any, please declare them. Has anybody got any disclosable interests? No? Okay, thank you. Item 3, minutes of the last meeting. To confirm the minutes of the previous meeting, 23rd of September. Has everybody read them? Anybody want to raise anything from there, or are we happy to approve them? Peggy proposed, Ed seconded. Are we all happy? All those in favour? Good, thank you very much indeed. Item 4 on the agenda, we're doing very well. Item 4 on the agenda, public question time. There are no questions being submitted. Members' question time. There were none submitted prior to the cut-off date. So we move on rapidly then to item 6 on the agenda, which is serious mental illness, excess morality. And I believe that Jackie Robinson is going to lead on this one. So over to you, Jackie. Thank you very much.
Thank you. Thank you. We have provided the slides, but I'm just going to come in later. Okay. So if you just need to skip through, that's just the open slides. I'm Jackie. I'm from the ICB, and I'm part of a partnership group today, where we're going to cover the questions that you've raised in terms of excess deaths and mortality, and also suicide prevention and the treatment and care that is provided by our partners in the Mental Health Trust. So I'm going to do the first section, and I'm going to hand over to Rachel. Thank you. Next slide, please. Oh, no, you've gone too far. Oh, yeah, okay. Just in terms of our commissioning requirements, that's the first slide. Yeah, can you see it? Yeah, principles, I should say. Yeah. Got it there, that's it. So in terms of commissioning, the ICB, what we aim to do is to try to do things once and building flexibility in terms of efficiency and in terms of, saving money and being fluid and working as things change over time with communities and with health needs. We are, a devolved organisation that most appropriate place to maximise that delivery of those outcomes and improve patient experience. We have integrated pathways of care that's focused their work around the place and working with provider collaboratives around mental health is one, for example. We do a lot of our work that is with people with lived experience, particularly in mental health. That's very, very prevalent. I'm sure you'll hear about that. As a challenged organisation, as are many in the NHS, we drive efficiency and productivity and work towards best value, and use those resources, with form a key part of our financial improvement plans. We have a commitment around the wider determinants of health and in terms of reducing health inequalities and social care inequalities, and also access and rural exclusion. Those are quite different and unique to those communities, so it needs to consider all of the challenges that the county where we share our risk in terms of our clinical and financial and operational through the partnership. We use an evidence-based decision-making model, and we move towards contracted for outcomes. So there will still be KPIs, key performance indicators, but it is about outcomes. And we recognise that there are lots of challenges, but also lots of opportunities so that we can continue to work together to provide the best offer of service by continuing to work to improve quality and release the finances appropriately. Next slide, please. In terms of monitoring the performance of our commission services, for this particular piece of work on serious mental illness, the work is monitored through a contract monitoring meeting, which is and a quality monthly meeting. So there are two separate elements to that. The GPs are also commissioned to provide us with health checks for those with serious mental illness, and the idea of that really is that people get picked up early and hopefully reduce the incidence of premature deaths. The checks normally revolve around 6 core areas, which is alcohol consumption, blood pressure, blood glucose, BMI, cholesterol and smoking status. There are key indicators of planning and monitoring the performance and the proportion of patients on the GP list who've got serious mental illness that they receive a full annual health check. The monitoring is undertaken to keep track of that progress during the contract meetings each month. The target is at least 60%. With a stretch target of 75, the current position at the moment is 50% of the practices. Nationally, it's sitting at 57. In locally now in Shropshire and East Shropshire, it's 63% for South East Shropshire and 40% for Taldock. And in addition to that, as an ICB with our partners in the secondary care sector, we also attend the regional NHS England Serious Mental Health Forums and primary and secondary care also partner on those sessions. Next slide, please. Next one down. So this is how people are classified who have serious mental illness in terms of excess mortality. There are national metrics and it's published data, which should be the theory, be the most latest and accurate data for serious mental illness. And this information I'm going to share with you today is Q2 24-25. That's the most recent. We'll cover the mortality rates for all ages. We'll cover cardiovascular disease, liver disease, cancer, respiratory disease as the main indicators. Next slide, please. In terms of deaths, the information death for Public Health England relates to physical mortality rates, but this is for people who have a serious mental illness. There are the top 10 conditions around asthma, arterial fibrillation, cancer, coronary heart disease, COPD, diabetes, heart failure, hypertension, obesity and stroke. And that data is from Public Health England and it's from 2018, which is the latest information we were able to obtain. Next slide, please. In terms of all deaths, the latest excess under 75 mortality rates for adults, the SMI show that Shropshire local authority to be statistically above the national average, and that rate is increasing in Shropshire for all causes. We'll break them down now. Next slide, please. In terms of cardiovascular disease rates, the SMI shows that both the local authorities have a rate that's in line with the national average. The trend analysis shows that whilst both areas have seen recent improvement in the rates, the latest figures are similar to those recorded 5 years ago, so it doesn't seem to be a great deal of movement. Next slide, please. This slide in mortality rate in relation to cancer for adults shows that Shropshire local authorities be statistically above the England averages, and that base is continuing to increase. Slide, please. In regard to liver disease, the rates for adults with SMI show that both local authorities are in line with the national average, and again, Shropshire has seen a gradual increase. In regard to respiratory disease, the SMI shows that both local authorities are in line with the national average. Shropshire has been seeing an increase in their rate, the most recent trends to have shown little movement. Then in regard to people on the mental health registers, the 4,000 people on the mental health register across Shropshire, Telford and Wrekin. A further analysis has shown is that the prevalence is the highest among the following PCNs for your locality, South West Shropshire and Shrewsbury, the rest in the Telford area. Slide, yeah. The population segmentation on the mental health registers is the prevalence is highest among those aged 20 plus who have a white British ethnicity and are living in neighbourhoods that fall within the 20% most deprived communities, which is calculated through the indices of multiple deprivation 2019. And it could also be seen that 67% of these patients have between 2 to 4 chronic conditions, so multiple mortalities. that's the end of my section. I'm not sure if you want to ask questions now or at the end, Chair.
I'd like to ask a question while it's fresh in people's minds. Can I ask that where Shropshire have got higher figures than others, the national average, are we targeted in those specific areas, or what are we doing to address them?
Sorry. Some of our slides will pick up the work we're doing around physical health and SMI and GP practices, if that helps answer the question.
Yeah, well, the question addressed. I just think that Shropshire is not in line with other counties. Therefore, what are we doing about it, and what can we do about it? That's really what I'd like to know. Yes, Councillor Anderson.
Just following up on that, is it because we're a rural county? Have you compared, say, other similar rural counties in terms of mortality rates? I'm trying to just get my head around why we're so bad.
No, the comparisons done through NHS England, Public Health England, and in terms of looking, shall we say, ICB to ACB, my understanding is that hasn't happened. To date, but it could have happened in the past. I'm new to this team, so certainly something I can check for you and feedback.
Thank you, Chair. Looking at all those diseases that are prevalent, you're looking at the complete spectrum of the population in the older group, particularly in the retired group. So, is there any point in identifying all of these particular groups, because you're talking about almost everybody in the older age group, and certainly it would be important for the younger age group where their disease prevalence is not as great, and we know that there are certain factors that relate to the different age groups, to young people, to those of working age, and those who are elderly, and so would it not make sense to split those out so that you can particularly look at the risk factors in terms of disease processes and other underlying issues in the various age groups? Because by lumping them all together, all you're doing is listing most of the common diseases.
Thank you for that. I think you make a really interesting point, actually. So our colleagues in public health, business intelligence have moved that information over for me, not that they can break that down. If they can, I will share that and send it over to your colleagues to look at. I can only cover today what's been shared with me, sorry.
Sorry, if I can just come back on that. The Public Health England have actually produced a toolkit for this type of area, haven't they? And has that been used in your developing your strategies?
Yeah, that's been used, and the information that was sourced from here is from Public Health England's course fingertips.
Thank you.
And that was used.
Thank you.
Thank you, Chair. I was just looking at the cancer rate, the excess, but it may be worth noting that I'm aware generally at the moment that in Shropshire, Ling and Davis is understaffed and people are waiting 6 months to start chemotherapy. And also there's a severe delay in MRI scans, CT scans for people who already got cancer. So I'm aware of one lady that's waited 6 weeks to be told that her aggressive cancer had progressed even further. So I'm just wondering if this impacts on this data. It surely will do. I mean, I'm talking specifically about the cancer rates. It's got to have some impact that actually our service there is not as good as it should be, then that will impact on your data here.
Obviously these have been sections of people who would die of cancer. You'll say there's not those who's on the register, but the proportion of those individuals, as Councillor Bente covered, that could be a large population of people because cancer is such a high prevalence. There is a dedicated cancer pathway in place as commissioning services to improve cancer outcomes. I didn't bring the data today, but if you would prefer us to ask our cancer lead to come and talk to you about that, I'm very happy to pass that message back.
Very much to look into that.
Please. Yeah, please if you can do that, thank you. Anybody else want to? Sorry, yes.
Just coming back on that, so that's the specific data about those people who are actually waiting for the results of their scans and the impact on their mental health. Have you got that data? Because that's the issue. Because I've got a number of people that I know of who've had a cancer scan, and it takes 6 weeks for the scan result to come back. They've had the scan, but the scan result, and it's the impact of that on their mental health. Because I know that it makes a fundamental difference to the way they're thinking and a positive viewpoint. So have we got data around those things? Because I'm really interested in that. Shall I ask my other questions after that?
Yes, please, Councillor.
But now or after Jackie's answered that bit?
Well, I think you better answer
that bit.
Allowed to ask questions.
So the quick answer to that is, Councillor Kidd, is I would need to speak to the cancer pathway. And what I can tell you is, as a woman who's been through the cancer pathway, I know how much it can be damaging to your well-being, and the waiting is actually worse than the treatment. So I will absolutely make sure we can look into that and come back, because it's really important to people once they've been
absolutely. And also, the co-leader of our group, his wife, has waited ages for the result of cardiac assessments, and it's taken weeks. Now, if you are suffering from heart failure in some description, and you do not know whether you're going to have another 2 stents fitted or not, that also impacts on your mental health. And for many people, that living between sudden death, because that's what it is, and not knowing when somebody's going to tell you whether you need a stent or not, or whether you're actually in danger, which it probably is an important factor to your mental health. So there are a whole range of things here, but each of these services where you've got delays and those impacts, which we ought to be measuring in some way, because it's a much bigger picture then, and it actually impacts on your physical health, as we know. So that's my other bit. So I've been quite interested in the rest of it as well. You're using statistics which are around multiple deprivation. It doesn't work terribly well in rural areas, as you would expect me to say, because we have, particularly the farming industry, that has all sorts of issues, and many of the people working in agriculture aren't living in very good conditions either, but because they're scattered across rural areas, we don't pick them up, and they're not in these figures in the same way. So although we were talking about the difference of us as a county, I'm not sure that we're stripping out the difference between the very rural dwellers and our more urban dwellers in the county, because I think it's fundamentally important. And we know that there's an increased rate, certainly in the farming community, for a number of reasons, but some of it is physical health issues. And if a farmer is unwell, has an accident, has any of those things, and can't get on with doing their job, the impact of that on the farm and the family is absolutely massive. And the rise in suicides could well be impacting on that. So there's a whole chunk of work that actually needs to be done about those very rural, isolated dwellers, as you'd expect me, Jackie, to raise.
No, and there is a rural health strategy.
I know, but they're not in here.
I can only give you what's on the fingertips, because I can't disaggregate them, but I can ask if it can be done for you. And I do think, following the work of the council, which I know you led, to look into rural health, it has made a real difference in the ICB, in that is a dedicated piece of work that's being driven through the strategy team led by Claire Parker.
I understand that. It's just that we've had a whole presentation about a very rural county where, yes, the majority of people live in Shrewsbury and Oswestry and Ludlow, but the others are very small settlements. So it would be really great if we could strip out some of those figures. So if we've got that, I would be great. Thank you.
And I'm happy to ask business intelligence for that. And I think the other point that you made is really important as well, in terms of the long waits and the anxiety that causes individuals. I'll speak to our quality and performance team who meet mostly about all of the contracts and raise that to be brought up at a contracts meeting. Given that it's something that's come to you as an elected member and local people, it's an important issue that we're able to respond to.
Yeah, we did do a lot of work on rural teams faster, didn't we? So I mean, this all comes into it. Paul Bowers.
Thank you, Chair. It was just, I want to come in a couple of points really. One was just a point of clarification. It's absolutely important, the point you've raised about people's anxieties in terms of waiting for health diagnosis. Technically speaking, they wouldn't fit into the group of people we're talking about, because we're talking about severe mental illness, and as Jackie described on the slide, that's a specific set of criteria. So, but the assurance on the point that I want to give is that in terms of our long NHS talking therapy service, we are actively growing the interventions that we provide for people with long-term conditions, which would fall under the group of people that you're talking about.
And those are the ones, what I want to prevent is them getting into long-term, because if you've got a chronic disease, if you don't get to the early services, actually you fall into the chronically mentally ill category, as many people do quite quickly. So it's that I'm interested in, and chronically mentally ill people do exist everywhere across rural areas and so on, because a farmer doesn't just decide to commit suicide just like that. Well, some of them do, but it's hidden.
Thank you. Rachel Robinson.
Thank you. It's probably actually to build on the point that Paul was making, just to clarify, I think, around some of the figures that we're looking at, and that we talked about, particularly the way that they're picked up for monitoring, and some of the outcomes data is very high level. So it'll be the same for suicides, and these are very small numbers. Same with some of the SMI numbers, they're very small and look at a particular population. I think it's really important to say that when we're looking at it being statistically significant, it's the whole population compared with a serious mental illness to those who haven't. So these are important things that we need to flag. There's something in terms of those pathways that mean that people who've got a severe mental illness are down prematurely for those who haven't, who've got cardiovascular disease and others, which is why we look at some of this. But your point is we need to look at more information and do a deeper dive. And I think some of the things that you've raised is really important about why we went through the mental health needs assessment, how we capture some of this. Sometimes we can't show all the data because the numbers are so small, but these are what we're talking about today in terms of both SMI and suicides are the tip of the absolute peak, and what we want to do is prevent all of that and avoid people. But we do need to understand the patterns around how we've ended, why we're an outlier in both serious mental illness and suicides, and all the work that's being done. So it's just, it wasn't to take away from any of the points. We need to capture that in the data that we're looking at. Where we can't have that information, look at proxy measures, because as you know, in rural counties the numbers are so small. But we are absolutely, through the audits we're undertaking, other work, starting to get an understanding of all populations, what different interventions might need to be put in place. So some of this, I'm capturing all of it, we'll make sure we pick up with the needs assessment, but it was just to flag really that what the data, that's why it's small numbers.
I did understand that, Rachel. Yeah. I'm just really interested in those bits that we don't capture at the moment, and actually how we feed into it, because unless we do the prevention stuff, we get more and more of the figures that are appearing here.
Absolutely, and you need to segment it to then make sure that you've got the right interventions in place. So it was just to try and clarify something. And I think some of the data around the registers is helpful, because it starts to show you patterns of where we've got numbers of people registered in rural areas. The other bit is where we actually don't diagnose it until it's too late, or we never know about it until it's too late, which is the bit we'll come on to. I think some really interesting patterns in there, and making sure that our interventions are targeted to those people who are the greatest need.
Can I just ask, when you look at the suicide prevention and so on, I'm noting that we're getting different figures in Shropshire than we may be in Telford. So how are we going to gather data on the locality? Is that the problem for us? Is that what we need to do? Because we're talking about comparing national levels, and we're different, are we not?
Sorry, in terms of
suicide prevention or mental illness. I mean, the figures are not compatible across the whole area, across the whole of the county, are they?
So in terms of some of obviously the serious mental illness data and suicide data, that would be we use the same data sources that we can get across the county. When I think when you start to look at some more local measures where you're trying to understand patterns and trends, we'll obviously have to use what information. So we might collect information through our joint strategic needs assessments, through some of the surveys that we run to try and understand how people's well-being is more generally. So some of those, you're right, we wouldn't be able to compare in the same way, but we try to build them from data sets where we can get national figures wherever possible. The challenge is how small you can cut down those figures into what numbers and making that meaningful. But it builds up a picture, and that's why I think the needs assessment is really important, because you build up a picture from a lot of different data sources to tell that. So the SMI and the suicide figures that go into the fingertips tools are collected across the country, which gives us a benchmark, but it doesn't then get into the granular detail we need to get into. So we've got to try and do both.
Thank you. Thank you very much indeed. We have Vanessa Barrow with us. Would you like to?
Thank you very much. Vanessa Barrett, I'm Chair of Health Watch Shropshire. And what I wanted to mention is, well, when Health Watch was set up in 2013, we were in a position then to give small research grants. And one of these went to a small group, a Shropshire group, of people with severe mental illness and their carers, to look at the impact of austerity as it was then after the sort of the financial meltdown in 2009. But they were looking at it particularly with respect to people that were living in rural communities. And because of this topic, I reread the report over the weekend, and I think it's still got an awful lot to tell us. And if you put lost in space in the search engine in the Health Watch Shropshire website, you'll find the report. And I think particularly the last section, which are about what the focus groups were telling the researchers, and their whole string of recommendations might be very helpful, not just in the sense of helping people with severe mental illness that feel very socially isolated, but also in the context of rurality in a much more general way. I think probably Heather might well remember it even. Her interest in this subject goes back much further than mine.
Good, thank you. Thank you, right. So we need to look at lost in space then, basically, is what you're saying. Good, thank you. Anybody else like to make any more comments before we move on? Yes, Councillor Bentley.
Thank you, Chair. Rachel, you alluded to the GSNA influencing the priorities for interventions, and you will know that one of the areas in my ward has a very high degree of deprivation, and in fact is the fifth most deprived area in Shropshire. But there are no targeted interventions in health that I can see for that particular area. So how do the JSNA assessments actually translate into physical help for known deprived communities?
Thank you. So we're obviously still undertaking the place-based GSNAs. It's a process where we're still moving around the county. And that's only one of the tools that we use in terms of getting down to that granular level. The purpose is that we develop action plans in each of those areas, and they should be joint. So this is not Shropshire Council, this is with partners and those involved in the needs assessment. And recommendations should come out of that about where we might have gaps in service provision and further actions. And we want to feed those into the various commissioning intentions, etc. It's not going to happen overnight. It's obviously resource dependent, and it's not just about one organisation, NHS, Shropshire Council, partners. It's about how we work together. But the GSNAs and the other needs assessments, so that mental thematic needs assessments, so in this case the mental health all we need to do, should make recommendations about where we've got we need to do further work and what actions we might need to take place in those areas, and they'll be developed with communities and with others, but that will be resource dependent as well. And what you would hope is that where we identify particular issues, so lack of primary care provision, in a particular area, lack of mental health services, that we would then work with the relevant partners and commissioners to, and services to try and support filling those gaps where we can in a managed way. That's the purpose of trying to move that forward.
Thank you. If I can just come back. As you know, we've corresponded about this issue for well over a year, and there seems to be no progress or little progress that I can see, and there doesn't seem to be any buy-in from all of the health systems that would be able to direct resources for this issue having been identified for over a year, but indeed it was also identified in the 2011 census as an area of deprivation. So at what point is there a timescale for us to see visible action in this very deprived area of Shropshire?
So I think the report you're referring to, I know we've had dialogue, and again, perhaps we need to continue that offline. The report isn't finalised in terms of the particular area that you're talking about. We're still working through that. Obviously, there's a time where we need to work through that with partners, and as commissioning cycles come around, to make sure that we get that into people's commissioning intentions. There's also a prioritisation process around that, but I know there is active work as we try to develop the action plan, and we can't do everything at once, but about trying to prioritise what activities take place in those areas. And I know it's probably a conversation for us to take offline away from this meeting, because we're talking particularly about things like ASB and social behaviour, and others that we need to prioritise and activities taken within the resources that are available. And I think that's the challenge that everybody's facing. But the needs assessment itself is to understand what those needs are and to make sure the partners are sighted on that, and we work together to try and address those needs. Unfortunately, it does take time to do that. But I'm going to check.
Thank you. But could you please give an indication of when that will be? What is the time it will happen? And I understand there are discussions taking place in the various organisation parts of the Shropshire Council and the other organisations to look at improvements, but they're not involving the local member.
So as I said, that report is being drafted at the moment. The data's being pulled together. It's an ongoing process, and we need to make sure that it does, as you said, involve bodies. So I'm happy to take that outside of this meeting to make sure we can pick that up with yourself.
Yeah, Mr. Secretary, I don't think that Rachel can give us an answer just like that today, but it is something I assure you that we will obtain an answer and come back to you. Are you happy with that? You're not?
Happy isn't a word I've used, but thank you.
You're content with that. Thank you very much indeed. Okay, we need to move on. And so the second part of the presentation is down to Paul Bowers. Paul, are you ready to speak? Oh.
Sorry, just to make sure I've got the right. Thank you. Apologies. It's not actually myself. I think Gordon's going to lead this item with Caroline and on suicide prevention for me to introduce it. And I think Gordon's going to take colleagues through the slides that have been shared.
Thank you. Thank you. Please.
Okay. Thank you, everyone. Do you have slides available? That's great. I'm making the assumption that people have had a chance to look through these, so I'll go through relatively swiftly if that's okay with people. But again, Chair, can I just check if people do have questions? Do we want to take them as we go along, or wait until the end?
We can wait until the end if you wish. Might be simpler.
Okay, that's fine. Thank you. Okay, if we can move to the next slide, please. And again. Okay, so again, responding to the questions posed by the group, just wanted to give an overview of what the national evidence identifies in terms of who is at most risk of suicide. Now, the key message I wanted to get across here is that actually there's no one reason as to why somebody may take their life or be having suicidal thoughts. It's a multifactorial issue. It's a societal challenge, and it does require all of us to be suicide aware, to ensure that we identify and appropriately address stigma, to encourage more people to feel able to speak about suicide, and ensure that we have the appropriate confidence and skills to manage those conversations and support and ensure people are getting timely, appropriate access to what they need. So what we have identified here, though, is that when, again, nationally, there's been a review on common themes, shall we say, as to what's happened in people's lives prior to their death. There are some key components, and perhaps these aren't too surprising to the group, but really important that we do flag those. Again, one of the key messages here is that these experiences by themselves, these risk factors, are not indicators of predicting risk of suicide at any one point in time. So they can't be used as a risk assessment by themselves. And actually what the recommendation is, what the evidence demonstrates is most effective, is the use of safety planning, which is working with the individual who is having suicidal thoughts and having that conversation as to what would that individual do and who would they contact for support in crisis. What are the assets in their world that could keep them safe and well? I haven't included it on here, but there is some online guidance around safety planning, which is accessible for anyone. And there's some really good information on the Samaritans website and the stayingsafe.net website as well. And as we said there, suicide prevention doesn't sit with any one particular group. It is all of our responsibilities, and we all can have a role to play. If we can move to the next slide, please. So this slide is outlining, again, what the national evidence has identified, that there are some groups that are at higher risk compared to the general population. But again, what I've highlighted in red is that although, yes, this is what the evidence has identified at population level, individually, any one of us can be at risk of suicide. And just because you're not in a high risk group doesn't mean that risk isn't present. So that's just something we also need to be aware of. That being said, for these groups, and recognise that there potentially could be others as well, but this is where the evidence is demonstrated in recent years. Again, we need to consider what support is available, how we can have those conversations, and again, that opportunity for those who work with these groups, as well as other vulnerable cohorts, what knowledge, what skills, what confidence do they have to have those conversations where suicide is discussed? If we can move to the next slide, please. And again. So apologies, this might be a little bit small, but this shows the recent, the suicide rate in Shropshire over the past X amount of years. Now, the latest reporting period is the 3-year average 2021 to 2023, which shows a local Shropshire rate of 12.8 suicide deaths per 100,000. In this latest reporting period, it is considered statistically similar to the England average rate compared to our previous period, which was statistically higher than the national average. Now, when we compare the Shropshire rate to the West Midlands local authorities, the Shropshire rate for this period is the 3rd highest. But when we look at what NHS England identifies as statistically similar and demographically similar local authority areas with a similar profile to Shropshire, the rate sits within the middle of the range. So it does raise questions that perhaps there is something about the rurality or the makeup of populations such as Shropshire that is different to other spaces that we need to be aware of in terms of suicide prevention and suicide risk. Yes, next slide, please. So as a response to that increasing rate earlier this year, the Suicide Action Group did undertake an audit which looked at coroner inquests where a death by suicide was recorded between 2020 and 2023. Now, we recognise that period was during the COVID pandemic and there was some disruption to usual recording and timescales, etc., which was also factored in. We looked at 114 inquests. The majority of the suicide deaths during that period were from males, and the majority aged in that 35 to 54-year-old range. So that's very similar to the national profiles. In terms of when we looked at postcodes of usual dwelling of where the person resided, there wasn't any significant difference based on usual deprivation scores. However, there's two things to just take from that. The first one is that, again, suicide can affect any of us. But on the other hand, what we are aware of is that we are aware of the number of social and health and other inequalities that can impact the most deprived communities. And we are aware that they are associated or can be associated with wider determinant risks, which in themselves can compound suicide risk. So it's just a really important one to be aware of, and important we do continue to focus on addressing inequalities. Half of the people within that time period from within the inquest were in employment. And again, the themes of the industries where people were working, similar to the national evidence in terms of higher risk occupations. So agricultural, forestry, fishing, manufacturing, building and construction, health, with some of the key common themes. We also recognise that roughly a quarter of those who died by suicide in that time period were retired. Next slide, please. So again, in terms of the risk and life events identified within the inquest in the 12 months prior to death, similar themes as to what the national evidence has identified. Again, one of the key things there, which is important with wider programs of work we're looking at, is that link with adverse childhood experience or history of trauma. And although there wasn't too much detail within the inquest that we were able to identify, certainly things around historic abuse, unmet bereavement need were highlighted. Also interesting to pull out that although not necessarily cause and effect, there were some physical illnesses also reported at time of death, including asthma, chronic pain, kidney disease, high blood pressure, osteoarthritis, diabetes, and cancer. And again, it's that opportunity to think about where are the contact points that people are or have been having within the system, and what can we be doing better to raise awareness of suicide risk, how to have those conversations, and skills to support with safety planning. And as it says here, that contact with services, the majority of those were recorded, their last contact was with a GP or with the mental health or a mental health service. So there is a programme of work that we are hoping to launch before Christmas or just after, as part of the Suicide Prevention Action Group programme across Shropshire, Telford and Wrekin. There is a toolkit that's been specifically designed for use by GPs and within primary care, and that's been supported by the GP named Safeguarding Leads as well, which is a toolkit supporting how to address suicide risk in patients who are presenting at GP and primary care. Next slide, please. So just in terms of some things or messages from the audit, because it is small numbers, as has been said previously, it's actually quite difficult to pull out themes and trends as to was there anything different that happened over this time period compared to previous time periods. What we can say is that the findings do correlate with national evidence, and there doesn't appear on surface level to be certain that there was any difference in terms of reasons why or situations that could have been different to other reporting periods as to why that rate has increased. And I think we've said the other points as well. Again, that importance of linking with system transformational work, ensuring that suicide prevention is represented across our strategies and policies, particularly considering those that impact or work to support our most vulnerable communities and cohorts. There is also a recommendation from the audit, and this is already being progressed, around how we can enhance our intelligence to inform about suicide and suicide risk. Now, I'll come on to it in a little bit, but we do have a system to record early identification of probable possible suicide deaths, but an area that we're still looking to enhance is records where a suicide attempt has been made. And we do recognise that is a challenge, not just for us in Shropshire, but nationally, because it does rely on a degree of subjectivity. But nonetheless, that is something we're really keen to explore with our partners. If we can move to the next slide, please. And again. So just a reminder, we do have a suicide prevention strategy for Shropshire. This is available on the Healthy Shropshire webpage, and there's an emotional health, mental health section within that. And as part of that, there is a page on concerns around suicide, which has a range of information, first point of contact advice, and within that, a link to the strategy. Now, the 4 overarching objectives of our strategy is to improve the data quality and intelligence so that we can have a more informed evidence-based approach for targeting interventions that are likely to, or hopefully will have the most positive impact. To improve outcomes for people that have been bereaved by suicide. We know the evidence identifies that bereavement by suicide can increase the risk of the bereaved taking their life or finding themselves in a mental health or social crisis. So really important that we have the right support and structures available to mitigate that risk. To ensure that we have a workforce that is suicide aware, a suicide aware Shropshire, Telford and Wrekin, and also what we can be doing to enhance those offers which are already available to support those where suicide and suicidal thoughts are present, and also how we can get smarter at targeting our messaging and our offers at those higher risk cohorts as well. If we can move to the next slide, please. So the next few slides are some themes as to what's been happening in recent times. So we have a real-time suicide surveillance system, which is a way that public health, the council, our local police and the mental health trust can identify recent deaths where it hasn't gone through the coroner process yet, but where suicide is a likely cause of death. Now, the reason for that is that we have an earlier opportunity to identify if there's any emerging themes or clusters, and is there something we need to be doing sooner rather than later to address that. What we've done recently as well, through NHS England grant monies, we've been able to recruit a dedicated coordinator to support with that collation of information, and we've expanded the number of partners that we're working with who can contribute towards this system. The purpose of that is to identify who were the contact points for that individual prior to death. So we've started working with domestic abuse, with Shropshire Mental Health Support, with our drug alcohol provider, Shropshire Recovery Partnership with you, as well as some other partners. We have also established, as part of the suicide prevention action group, some dedicated workstream subgroups with inviting people who may not be part of the usual action group, but who have those greater insights to those cohorts that we spoke about earlier, and can understand some of the barriers to access for support or some of the difficulties or opportunities that we could have to target those messages, and what does good look like, or what could impact involve. So to date, those work streams that we've established and had initial meetings for are people who are already known to services, men as a general population, rural and farming communities, military veterans, people at risk from wider determinant social risks, and children and young people. If anyone does want to support any of those conversations or work streams, please do reach out and we can have a conversation. Can we move to the next slide, please? So again, some examples of work that's already been carried out, and taking opportunities to ensure that those who have greatest reach have appropriate suicide prevention skills and knowledge to support. So for example, our farming and rural health check programme, all of the staff who are supporting with that have been trained in suicide first aid, and we're also looking to continue those conversations with the wider community, those who may not be farmers themselves, but have that link into the community so that we can connect training, support, raise awareness of what could be available to support within those communities, including safety planning. And as we said about the suicide bereavement support, we do have the Suicide Bereavement Service, which sits across Shropshire, Telford and Wrekin. That's delivered in partnership by Shropshire Mental Health Support and Telford Mind. We also established over the past year a local branch of the National Survivors of Bereavement by Suicide peer support group. So that is for adults specifically to have the opportunity to talk about what's happened, share their feelings, share their stories. And we currently have 2 groups which are established in Shrewsbury and Oswestry, with one hopefully starting in Telford soon. We can move to the next slide. And again, yeah. So we've mentioned about the GP toolkit, as I say, hoping to launch that prior to Christmas or just after. There's also been work linked to the river safety programme. So we've worked with the Samaritans to install signs on the bridges, particularly to start with around Shrewsbury. There is still a little bit more to do, but that work has started. And again, that opportunity to signpost what support is available in those moments where somebody may be not in the best place. We also really keen to continue promotion of the various suicide prevention resources that are publicly available. We do use World Suicide Prevention Day, which is the international suicide awareness campaign on the 10th of September as one of our vehicles to encourage conversations around suicide and again to address stigma. We do also have physical copies of a Z card called Pick Up the Phone, You're Not Alone. So this is a wallet-sized card with first points of contact information. If you're concerned about suicide in yourself or someone else, who can you contact? We have shared these with a range of public spaces, including GPs, libraries, food banks, a whole range of spaces. However, if you're aware of a place that doesn't have access to these and feel it would be of benefit, again, please do reach out. We do have a digital version of this as well, which is available on the Healthy Shropshire webpage. There's also a NHS Shropshire, Telford and Wrekin Suicide Prevention Resources page, which has a range of advice, guidance and links that people can use if they're concerned around suicide in themselves or if they're supporting somebody else. And as I've mentioned, we do have the Shropshire Healthy Lives emotional wellbeing mental health pages, also with local information about what support's available, how to signpost and who you can contact if you do have concerns. We can move to the next slide, please. And within that Healthy Shropshire page, we do have a broader first point of contact for mental health or emotional wellbeing needs resource document. So It's not a database. We were really keen not to create a database because of the challenges in maintaining that, but we did feel that it would be useful to have a resource that can be used by anyone, which outlines if you do have a concern, whether about suicide, whether about mental health, or whether about a wider determinant risk that can influence mental health or suicide, who could you contact in that first instance? So just highlighting there, these are the categories that are currently within that resource. It is available on that link there as well, but it is being refreshed. We've asked for that to be reviewed twice a year just to ensure it is kept up to date, and it's currently going for a refresh at the moment. So if you haven't had a chance to look at that, I do strongly recommend if you could, and again, happy for any feedback. Please move to the next slide, please. Okay, so again, this reinforces the ambition to create a suicide-aware Shropshire. We have had some grant monies through NHS England, which has enabled us to provide some subsidised suicide prevention training opportunities for some of our workforce across health, social care and the voluntary sector, and those who work in the community. So we have a range of offers that are available, ranging from suicide awareness provided by our joint training team and suicide first aid, through to some more in-depth 2-day courses as well. So again, we would really encourage people to continue being aware that this is an offer that is available, and to reach out if they haven't seen this or would like further information. I have included there some examples of agencies that have already participated, and during the past year 23-24 we had roughly 200 people from across different organisations complete some form of suicide prevention training. We also continue to promote the Zero Suicide Alliance free online training. So this is something that's accessible to everyone. You don't need to be a health or social care practitioner or professional. It is aimed at everyone. You don't need any background knowledge in suicide or suicide risk. However, we are strongly advocating Zero Suicide Alliance is included as mandatory training across all of our services and organisations, as it does provide a fantastic baseline and introduction to the topic and how to have that conversation. And as an example, we've worked with the licensing team over the last year as well to build in suicide risk within the safeguarding sessions for licence applications. So again, all of these opportunities to encourage people to be aware and have those conversations, we're really keen to explore. We can move to the next slide, please. And that's just a snapshot from the Zero Suicide Alliance webpage. So you can see there's a range of different categories there, including some more bespoke, shall we say, information. So you have the catch-all suicide awareness training. There's autism and suicide training. There's a military veteran specific focus, a taxi driver edition, a prisons version, a university student edition, and a probation staff. There's also suicide awareness training available in the Welsh language. So again, we would really welcome if you could support us to continue promoting the Zero Suicide Alliance, the free online training. Next slide, please. And again. So this is just some examples of how partners are working together to mitigate suicide risk. So our action group is multi-agency, as are our work streams, and any of us who have insights and are able to contribute to those discussions are welcome. So again, just reiterating, please do reach out if you're aware of anyone who would like to support with those conversations and programme of work. I've put this in as well. It's not specifically suicide prevention in terms of the label, but absolutely recognise the impact it can have in mitigating suicide risk, as well as in improving outcomes for people with co-occurring needs. So we have a task and finish group, which is exploring how mental health services substance use services and domestic abuse can work in a more systematic, coordinated way when somebody does present with a co-occurring need, and how to effectively jointly assess that person and create a joint care programme, and keeping each other up to date to ensure appropriate progress through that care programme is being seen. So that's a programme of work that's currently being explored and delivered at the moment. And we are looking to establish new suicide death review panels similar to the drug alcohol death panels to better understand what's happened for this person and what we can recommend or feedback to both partners who have been involved and to the wider system for any potential opportunities or gaps that could be addressed. Next slide, please. And again, similar to what we said before, we continue to advocate for suicide prevention being a key topic within all new policy and strategies that are being created that support our most vulnerable across our communities, as well as those high risk cohorts. Advocating, I know it's difficult at the moment in terms of time and capacity with demand increasing, but time to actually access suicide prevention training, or to be able to identify someone within the team or organisation that could be best placed to attend and feed that back to the wider team and organisation. That link with the wider transformational programmes which we've spoken about as well. So we are ensuring that integration of suicide prevention training for programmes of work such as our community hubs, the social prescribing programmes of work, obviously our trauma-informed system conversations, as well as the children and young people's integration programmes as well. And I think it's going to be on one of the later slides, but partners are also working together on the Community Mental Health Fund for adults, with the latest round being focused on voluntary sector grant applications focusing on suicide prevention. So fantastic that we've had that opportunity, and partners have been reviewing applications for that as well. Next slide. And I just wanted to leave on this slide, which is just a quick snapshot of who you could contact if you were concerned about suicidal thoughts, or if you're caring for someone who is struggling with suicide. These are national numbers: Samaritans, the crisis text shout line, and Papyrus for supporting any child or young person under the age of 35. So I think that's my last slide. Yeah, okay. Thank you.
I thank you for that presentation. I found that very, very informative. You've covered, I've written down loads of questions, I've had lots of questions, and you've covered most of them, or quite a lot of them. One thing that did surprise me, Papyrus, I've never heard of them, so I don't think your communication or the communication of this is good. Put it that way. There must be some way we can publicise and get things a little bit better. I wanted to ask about children. I wanted to ask about the effect of gender and race, and also global wars. What's going on at the moment with politics, with people being frightened to turn on their heating because of costs and so on, the cost of living crisis, the global conflicts in Russia and Ukraine, etc. Are they having a difference, or have you noticed a trend at all?
Yeah. So again, we have to look at national research on this because the numbers locally are small. But yeah, absolutely. There's I can't give you cause and effect, but absolutely anything that's happening that can increase people's anxieties, worries about what's impacting them locally or nationally, or their families as well, can compound risk. Absolutely. So things like the cost of living crisis that we've experienced over the last few years, that has put additional pressures on people in terms of, obviously I don't state the obvious, but by itself it might not be a direct risk, but it can be a compounded risk when factored with everything else that's going on in that person's world.
Thank you. And what about children?
So for children and young people locally, there hasn't been a recorded suicide death of a person under the age of 18 in the time period that we've looked at. However, what we have seen nationally, there was a research program undertaken by the Samaritans, granted it's a couple of years ago now, which was showing increasing anxieties and mental health concerns of children and young people over the past few years. Particularly for people under 25, there was increased self-reporting of thoughts of suicide. So we do need to be really aware as to what that means in terms of the support that's available, how we can ensure education, schools, parents, carers, etc. have access to the right information, as well as for young people themselves and what that means for them within their world. And we do know for young people, again, perhaps it's no surprise, but the common themes nationally where there has been a death by a younger person, themes around bullying, school pressures, exams, family disruption, history of traumas have been common themes. So again, really important that all of these programs of work are not sitting in isolation, but are joined together.
What about the internet? Does that cause a problem?
Yes, absolutely. That's a really good point. So in terms of accessing information online, there's both local and national advocacy about how we can get smarter at protecting young people online. And there are a number of resources that can be used to protect what web pages young people can access. So I believe some of that information is shared on the NHS Shropshire Telford and Wrekin resource page, and if it's not, that's something we can ensure is linked to. But absolutely, we do need to be aware of what our young people are looking at and recognise the challenges, particularly with mobile phones and how people can access. But there are things that people can use to help protect our young people.
Thank you. One of the questions I wanted to ask, and you probably answered most already, is that we've noticed from the quarterly performance reports that the rate to access deaths for people with serious mental illnesses has been increasing and is now above the national average. Can you explain, is there a trend as to what's the measure of it? Can you comment on why rates have increased in the last quarter?
Do you mean for suicides or for so we don't have the quarterly information for suicide deaths, but because it looks at a 3-year average. So we get the data from OHID Fingertips, which is the national system where we can compare local authority areas and NHS areas in a statistically significant way. We did undertake the audit, which was the purpose to see if there was any significant reasons or anything different that may have happened during that period to other periods. And unfortunately, we weren't able to pull out any meaningful information of any specific differences. It does seem to be a continuation of the common themes or the usual risks, shall we say, that we experience locally and nationally. So it's difficult to answer that question with any degree of certainty, I'm afraid.
Thank you very much. So I do think your presentation has covered a lot of the points I think we're all aware of and concerned about. I know we have additional questions because we've got a list of them. Councillor Mullett, would you like to?
I think you actually asked the question.
Okay, we'll move ahead of it.
What I want to ask is actually around the training, because I think the training is quite a fundamental part of actually improving the whole system. It's probably not on the list, but I just want to ask the question. You said there were 200 people trained last year. Is that the capacity? Can we train more? Do we have a target for training more people to be involved? And if people, and there is obviously going to be a problem with access to that because of the pressure of work and the lack of staffing and so on across the board. But do we know how effective it is when somebody comes from a team and is trained and then passes it on to the team? Because some people are really good at going back to a team and imparting that information and training in a way that is useful. Other people are not. And I think that's part of the work. I'm also interested in the cross-border stuff. Pick up the phone, you're not alone. Do any of those things manage to get to GPs and so on across the border? You did a Welsh document, which was interesting, and there are Welsh speakers across Shropshire and so on. But there are a number of GPs along the border who have lots of Shropshire patients. And I can't remember seeing, not that I go to my doctors hugely often, but I can't remember seeing anything like that that wasn't actually covered by the Paris Teaching Health Board, and whether if I wanted that, I would only be able to do a Welsh one.
Yeah, really good points. I'll address the training one first. So what we encourage, particularly for the grant-funded access, the no cost, if you will, for those who can access the suicide prevention training, we do ask that teams and agencies can identify the person who is best placed to share that information. So we do ask that people, when they think about who is able to attend that training, if they're also a good person that can then spread the learning within that team as well. Another option we can do, again, it does depend on who the team is, where they sit, and the cohorts that they work with. We can also offer some bespoke training, recognizing that actually it can be challenging during the usual working day. So we have provided some out of hours options as well in those cases. It is based on conversation with the team and the agency, though. I would also highlight that we do have a limited amount of funds, unfortunately, to deliver the subsidised access. However, there is other opportunities or other options that are available, particularly for those with access to a usual training budget. And that is something that can be provided by our joint training team. And there's also some fantastic wider offers, including Assist, which is a national 2-day in-depth training suicide prevention offer. And we also have something which is targeted at those supporting children and young people. However, currently the licence is only for those who are employed by Shropshire Council, but it is available nationally as well. But that's where the Zero Suicide Alliance free online training is a fantastic resource, because it doesn't go into as much detail, obviously, as a full day or 2 days training, but it's a great way to start being aware of how to spot risks and symptoms, how to start a conversation, and how to signpost. So that's something we really do encourage. With regards to the next part of your question in the Welsh or the border working, we have reached out to Paris and NHS Wales. It has been a little bit slow, if I'm honest, but we have had our suicide bereavement officer from Shropshire Mental Health Support, who has recently spoken with the suicide prevention lead from Paris to start bridging those connections. There's a lot more we would like to do, but it's, should we say, one step at a time with that, but absolutely some really important opportunities that we want to ensure are connected.
Just to come back slightly, do we have a target for how many we want to train in this? Because it will make a fundamental difference across all sorts of different services. And do we look at services within the council that actually haven't taken it up and say, really, you ought to be doing that? And
So really, yeah.
my other next bit is, and I'm not sure I'm asking the right person, but we do often have a problem with GPs. In that not all GP surgeries are really good at making sure that the whole team picks up the training that they need, which is outside the council, obviously, but we have an impact. The safeguarding lead is one thing, the whole team is a different thing.
Yeah, absolutely. And again, to answer that question, we don't have a specific number. However, as I say, we are limited by the amount of funding we have to deliver the subsidised training. However, we do have a training needs document, if you will, which outlines the teams, the agencies that we would hope to have accessed some form of suicide prevention training. So we are continuing with that, and we do have a workstream group that is focused on that as well. My honest answer is, ideally, everyone who works in health and social care and the voluntary sector would have had some form of suicide prevention awareness training, whether it be the Zero Suicide Alliance or one of the programs that we can connect, or one of the broader ones. So it's a bit of a cop-out answer, but actually, going back to what we were saying earlier in the presentation, it is all of our responsibilities and we all have a role to play. That being said, further conversations around those who haven't engaged, that's something that we are exploring through the action group, and would welcome advice perhaps offline as to how we can better connect those offers. And absolutely, with the GP connections, that's a really good point. With the toolkit that we're looking to launch, we are looking to do that through the GP board as well. So it has been produced with support from the named safeguarding leads, but it is aimed at all of our GPs. There's two parts to that toolkit. There's a quick reference guide, which is a 2-page, what do you need to know? And there's a, shall we say, fuller resource kit that sits behind it for those who do like to have that additional information and detail.
Thank you. You raise a good point there, because if it's more difficult to access a GP surgery, and a lot of their work is now being farmed out to pharmacists, pharmacists that, you know, on your list of people that you should train, because that's a very secondary point of contact, is it not?
Absolutely, and we've worked with our local pharmacy committee, LPC, over the past couple of years. It is, should we say, similar challenges to our GPs in terms of time to release for some training. However, we have had a number of pharmacists and those who work in pharmacies who have attended suicide prevention training over the past few years. But we do absolutely continue to promote and encourage those opportunities. The toolkit, we did put the question out as to whether it's something that pharmacists and pharmacies could also use. And there are some obviously slight nuances that are different between GP and pharmacy, but actually the underlying principles are quite similar in terms of how the toolkit can be used. So we are looking to share that with broader primary care as well.
Good, thank you very much. Councillor Hilary Luff.
Thank you. Just as a point of note, really, all teachers and early years people have to do safeguarding training every 3 years. We do it on domestic, you know, within that safeguarding is on domestic abuse. How would it not be a good idea to include the suicide risk included in that training? Because a lot of our nurseries are very rural and a lot of our schools are very rural, and parents often talk to teachers and nursery staff quite openly about things that are going on in their lives. And I just wonder if it would be a good idea just to have it as standard put into this mandatory safeguarding training that they all have to go through every 3 years.
Yeah, I think that would be a great opportunity if that's something we could connect, and I would welcome a conversation with the person that organises or coordinates that. What I would highlight as well, for schools and education, we do also have the Future in Mind programme, which is aimed at those who work in schools and colleges or who work with children and young people in Shropshire, and specifically focusing on the emotional well-being needs of children, staff, and the whole school approach. So there are also opportunities through that Future in Mind programme to have conversations around the needs of young people. In the past, that has also looked at suicidal thoughts and self-harm as well. So that's another opportunity to tie things together. But absolutely, I would welcome a conversation on progressing how that could be considered and delivered.
Good, thank you. We've made a note of that, and I'm sure we will be communicating with you. Councillor Bentinck.
Thank you, Chair. Clearly, there are a large range of issues involved in trying to reduce the strategy, but of course, one of the most important is whether it's going to actually work. Is there evidence of specific interventions in geographical areas or communities that have actually reduced the incidence of suicide? Because we're seeing a gradual rise, and certainly there are nice guidelines, and I presume you've used them in constructing your services. But where is the evidence that the interventions that we're looking at are going to actually achieve a positive outcome? I wonder whether a zero aim is actually a pipe dream, because I don't know any community that has a zero suicide rate. I'd also like to ask, is there any tracking of people who have visited the various services who are considered to be at risk of suicide to see whether their mental health is improving or not in relation specifically to suicide ideation? I would like to ask about the local hubs, because I think mental health services are starting to be delivered by those. But of course, South Shrewsbury doesn't have a hub at the moment, and I wonder about running out of funding before it's actually established. And I'd like some information on how and when it's going to be provided within the South Shrewsbury area. The Rough Sleepers Medical Clinic, I understand, stopped at the end of October 2024, and this is a big group that's at risk of suicide. How is that medical provision going to be continued? Finally, one of the quality statements in the NICE guideline for suicide prevention talks about a media strategy. And can I ask what media strategy you have leading up to Christmas, which is a very high time for suicides? It would be great to have all of the deliveries of the service to respond to that. Thank you.
Okay, thank you. Really, really good questions. I'll take them one at a time. So, first one, I think you asked around the evidence base. I suppose the best answer I can give you to that is there's no one intervention that's going to work for everyone, because it really depends on what's happening in that individual's world and what could be part of their safety plan to protect them. And so actually what the evidence does say is that there's a number of common themes that we should be doing across all of our services and communities, which is around addressing stigma around suicide. We do recognise it is a difficult topic, and there can be concerns that by mentioning the word suicide, you might put the idea into someone's head, or the implications if you yourself are having suicidal thoughts, what could that happen? So it's really important we continue dispelling the myths around suicide, encouraging people to talk, and accessing that help when it's needed. So we do. Yep.
That's for evidence of outcome, evidence of improvement, of reduction in suicide rates.
And again, because the reasons for suicide are very complex, so you might be able to target certain aspects in part of the community, but it's not really a simple answer, unfortunately, in terms of a direct, if you do this, you will get this outcome. However, that's where places have succeeded in reducing their rates, addressing stigma, ensuring that you do have a appropriately aware workforce, ensuring that people do know what support's available and how to access it, are the common themes. But there isn't really anything directly that says if you do this you will get this outcome, because it also it relies on your local geography, who your local people are, what services you have available, how can you access them, and everywhere is set up in a slightly different way. So unfortunately there's not a direct, shall we say, answer to that, and that's where actually it's really important to have that localized discussions of people who are aware of what are the concerns of local people, what is happening in the local economy, what's happening with local services, how can we work together to arrange them in a way that is going to be impactful for our community. And that is what we're trying to do through our conversations. In terms of tracking of services, it's not something it wouldn't be done by the action group. So I can't speak for other services. However, the feedback we've had from people with lived experience who have been impacted by suicide and had suicide attempts previously is that suicidal thoughts isn't a condition that you can just solve, so to speak, in the sense that it's something that is there, but you can have strategies and resources and support in place that helps manage that. So again, that's where the safety planning actually really is important. And actually, sorry, going back to that evidence question, that's where that actually is there is some good evidence of having effective safety plan that's created with the individual, so that they can recognize when they are in those times where they're finding they're at risk of crisis, or they're having the suicidal thoughts and things are getting a bit overwhelming, who they can turn to, who are the main contact points that will keep them safe and well in that moment, or what can they be doing that can manage that in that moment. In terms of local hubs, I'm afraid I'm not able to directly speak to that. It's more about how we are linking with community assets and those who have that reach into the community to connect the suicide prevention training and awareness. So it was just an example of one of the areas which we're trying to work in an integrated way in a partnership approach. So I'm afraid I can't specifically answer that one. With the Rough Sleepers Medical Clinic, similar response, but absolutely recognise rough sleepers are one of the high risk groups. We do have our reset team as well, which supports our rough sleepers with a drug alcohol issue, and I believe there is a rough sleepers element within the MPFT presentation as well. But again, in terms of the support, we have ensured our reset team who do work with that community have all been trained with suicide prevention, first aid, and we do encourage, again, anyone who does work with that community or that cohort of people, if they haven't accessed training, to access it, and happy to have that conversation. With regards to the media strategy, yeah, really good point. The festive and New Year period is a difficult period for many people. We're looking to repeat what we did last year, where we had a poster and social media campaign. The poster utilising similar contacts that was shown in that last slide, as to, in a period where perhaps access to usual services may be reduced because of it being Christmas and New Year, these offers are available 24/7 every day of the year. So we are looking to repeat that. Last year we sent it to parish councils and libraries, a whole range of other spaces, and to ask them to display it in how can I put this, high footfall, but spaces where people can see those posters even if the organisation itself is closed. For example, library front windows where people walking past can see that information. We do have a comms strategy that sits behind all of our suicide prevention work as well, and we are working with our local comms team and the wider system comms team as well to continue promoting that information. However, we do recognise that we are also reliant on our partners and others to help us to get those messages out. So if there are things that I've spoken about today that you weren't aware of, or that you feel actually that wasn't known in your community, I'm happy to have that conversation to think about how we can do something perhaps slightly differently to enhance the reach of those messages.
Thank you. I guess that the council will distribute those posters to members.
Absolutely.
Thank you.
Thank you very much indeed. I'd like to, as we said, papyrus, I've never heard of them, so I'd like to really share that from the rooftops in my community. Thank you. Councillor Fallon.
Oh, thank you. Thank you very much. Some of these questions you might think you've gone over already, but it helps, I think. My first question is going to be, I think you may have answered this, was that not everyone who commits suicide are known to have a mental illness. And maybe they haven't had a long history of it. It's just something that's happened, like, you know, they've lost their job or something like that. How do we risk that? How do we identify people that might be in that sort of category? Could you answer that? I'm guessing that a lot of it is sort of the Samaritans, that sort of thing that you're hoping for. But also, I was going to ask a question later. I'm sorry if it's a bit mixed up, but how do you identify them people? And people that are most likely to identify it as a problem are spouses, partners, family. And now I can't even, my wife can't even reorder a prescription for me because they won't let her do that. So when it comes to this sort of thing, it's that person who's got to make their own appointment, and maybe they won't. So sorry if it's a bit mixed up, but that's the question.
Yeah, no, really fair question. So absolutely. So we're really keen to emphasize that being impacted by suicidal thoughts isn't a mental health condition. It's not a mental health issue. It is something that can impact anyone. However, again, looking at the national evidence, what they've identified is from people who have taken their lives, roughly a third of people have had some contact with mental health services. So they are a risk group, but it's not always going to be everyone with a mental health issue is going to have suicidal thoughts, or everyone with suicidal thoughts has had a previous mental health issue. So that's something really important. And it is tricky to be able to identify it, and that's where really we need all of our services and those within the community who have those contact points with people, really, to have that awareness on if something isn't quite right, how can you have that conversation, or how can you notice? Sometimes it is more obvious than others. Someone will say things, and actually there is some guidance on the NHS Shropshire Telford and Wrekin as to the use of language, and actually being able to recognise what people are saying, and in that itself being part of the risk assessment, if you will, and also how you can use language yourself in a non-stigmatizing way to open up those conversations. And that's really the key one, is that by speaking about suicide, you're giving that person permission to talk about how they feel. What we said within the GP toolkit is actually recognition of the role of family, carers and that person's network. So if there are concerns, how can that be appropriately discussed with those who are part of that person's world? Absolutely, what we identified through the audit as well, there were a few cases where, for all intents and purposes, there was no obvious risk signs, there wasn't anything that was spoken about, there was no and it's difficult because I'm basing this purely on what was in the inquest. I don't know the details about the specific case. So it could be that it's not always going to be that readily accessibly easy to identify that risk, but having a society and structure which is more open about talking about suicide hopefully should encourage people to feel able to reach out and to have those conversations. And just picking on an earlier point, we were talking about the zero suicide ambition. That is, I guess, our philosophy. That's where, in a perfect world, that's where we would want to be. And we recognise, no, it's absolutely not a target, but actually the more we can be doing to encourage people to feel able to speak about suicide, for those who are supporting others to have the confidence to have that conversation, hopefully that should have a positive outcome to ensure that person has hope, to feel they can reach out, to feel that there is somebody who will listen and will care, and there are people who will listen and will care.
Okay. Thank you. Can I move on to?
Yeah, sure. Thank you. So really make whatever actions we do, it makes a difference by talking to people, basically.
Absolutely.
I do have a list of questions from lots of them around the table, but I'm anxious to bring Paul in for his comments and would you like to comment on what you've heard or you'll finish your presentations?
Hopefully we'll pick some of them. Sorry, hopefully we'll pick some of that up during the presentations if that's okay.
That's fine.
I mean, a specific thing around comms as an organisation, we usually we've got social media channels, Facebook and X. So we usually push our access point contact details through those around Christmas as well. And although we haven't had specific details, I don't think yet, my sense was that I think I talked to the group last time about the mental health option through NHS 111. My anticipation was that would be pushed out on the winter pressures campaign as well. So yes, it's on our agenda too. But yes, if we move into our presentation, hopefully we'll pick up some points, but happy to.
Just to add, it's on the ICB's agenda as well. It goes on to our social media. There's a dedicated web page, and they are working with the council's comms lead at the moment. So we would use all our channels across the trusts, across primary care, secondary care, to make sure that we can get as far as we can.
Thank you, Jackie.
Okay, thanks very much. Hopefully, as you've seen then through the two previous presentations, the Integrated Care Board, the local authority, use national data to derive a local understanding about pictures and trends. And when they've got that sense of direction, they commission organisations like ours to provide a key range of services that we hope in time start to shift the dial on some of those adverse figures that we've seen before. So our slides are just going to focus on a few of the things that we're doing really in both of those spaces, the physical health and severe mental illness space, and then the work around suicide prevention as well. Talk a little bit about how we do that in partnership. So that's it. So yes, if you can skip the first couple, that's the header slides. So I mean, the first thing, I'll take it as read that people understand that you can be referred into mental health services for a range of avenues, really. General practitioners, emergency services, acute hospitals, family members, etc., etc. There's a range of ways into services. What we want to build, obviously, is the means for people to be able to contact us themselves if they're concerned as well. We don't want you to have to wait necessarily for a professional referral. So for a number of years now, do the maths, Paul, 8 years, I think 2016, we set up a 24-hour-a-day, 7-day-a-week, 365-day a year access line, which was allowed people to refer themselves into our mental health services where they were concerned about their mental health or concerned about the mental health of somebody else. More latterly, that service has also picked up the traffic that comes through the NHS 111 mental health route as well. So as I mentioned last time, a mental health option has been rolled out nationally now as part of the NHS 111 offer. When people dial that locally, they'll be signposted through to our access service, and we'll pick up the triage and support from there. For groups of people who would usually have the conditions that fall under anxiety and depression, we've got what used to be called Improving Access to Psychological Therapies. It's been rebranded nationally as NHS Talking Therapies for Anxiety and Depression now. Again, we've got self-referral portals as well, both online and by phone, where people can get in touch with the services to refer themselves in for therapy and treatment. I will hand over, I think, now to Claire, who's going to talk to us a little bit about physical health services for people with severe mental illness, and then I think about the rough sleeper service as well, if that's okay.
Yeah, thanks, Paul. It might move to the next slide.
Can you bring the microphone a bit closer to you?
Yeah, so one of the services that sit within my portfolio is around physical health for people with a severe mental illness. To put into context what NHS England define as severe mental illness in this context is people that have a diagnosis of either a psychotic illness, such as schizophrenia, or a mood disorder, an example being bipolar, and are on an antipsychotic medication and or a mood stabiliser. And the reason for this group is because we know from statistics that the lifespan on this medication reduces someone's lifetime by in between 15 and 20 years, which is why this is the cohort that NHS England are wanting us to primarily focus on. So it's quite a high level, but what we have within Shropshire is two services, a secondary physical health service and a primary physical health services. All our checks are based on NICE guidelines. So in secondary care, we have a service for everybody that's initiated on antipsychotics and a mood stabiliser in secondary care. And these people are reviewed every 3 months and remain in that physical health clinic for up to 12 months. And then they are moved on to their GP practices, SMI clinicians, which also work part of MPFT. We are in all 52 GP practices across Shropshire and Telford. Within that, we have 2 clinicians based in Shropshire, 2 in Telford. And as they say, they cover every single GP practice. We use a range of technology in order to try and improve our efficacy. Obviously, one of the barriers we've picked up in Shropshire is around GPs and blood. Obviously, patients have to go to either Princess Royal or Shrewsbury to get their bloods done. So we're using technology through WASM boxes, Affinia machines, where we can take people's blood on site for cholesterol and blood sugars. So we're able to do at that point identify if they have had a high blood sugar, so HbA1c that's raised, which would indicate diabetes, or raised lipids, which would indicate some cholesterol needs, so we can refer to the GP directly. We've also been linking in very closely with our local authority, social prescribers in Shropshire, got strong links with public health, and offered a range of activities, both through the local authority, social prescribing, but also our own. We have a specific FMI physical activities that we initiated 2 years ago, and this started off in conjunction with Tennis Shropshire. And we now offer a weekly tennis session for anyone who has a SMI from 18 upwards or a mental illness. And these sessions are free. They're every Wednesday at the Dome at the Shrewsbury Club. We provide tennis equipment, a coach, and they've become really popular. And we even actually made BBC News, which is the first time apparently that this actually got onto TV. And I've since found out we're the only trust in the country that is working with their local authority tennis provider. We've also created our own Couch to 5K, and we're currently working with Energise and the 2 local authorities and have pulled a bid together in order to provide football through Shrewsbury Club and Telford, as well as Nuffield Health, so we can increase our physical health offer. And Shropshire Cricket as well have also bought into that. Just currently trying to find a grant scheme that's big enough to support the range of activities we wanted to provide for this cohort. We've also recently made links with SAF in relation to breast screening for those eligible with an SMI. Obviously, we know with this cohort they are a difficult cohort to engage. And what we're finding is that people don't generally attend their appointments. So working directly with the breast screening clinic, if we do have a service user within one of our clinics who meets that criteria, we can make a direct link with the breast screening in SAF to understand have they been for their screen. If not, encourage and support that person to make the links. We've also just recently started providing an outreach clinic. Again, for multiple reasons, we go to a lot of nursing homes. Rurality, obviously trying to get to GP, especially in these sort of weather conditions, is challenging. We do have a high DNA rate again because of the cohort that we work with. So we've now got a dedicated outreach worker that works 3 days a week to try and reach those SMI patients that aren't coming into clinic. We've linked in with the Rough Sleeper team, and I'll talk more about that in the Rough Sleeper slide. And that again is providing those physical health checks and going out on the streets with the Rough Sleeper team to do those physical health checks for those with an SMI. We've now also brought a psychiatrist linked into the team to support the nurses should there be any adverse effects that we've seen or any concerns. And we've got an advanced pharmacist going to be working with the team 3 days a week, supporting practices and clinicians around complex prescribing, where we're seeing a mixture of antipsychotic medication and high doses of physical health medication. We're active members of the regional and national physical health SMI forum run by NHS England. And we've actually had really positive feedback from our GPs about how effective the SMI clinicians are in the practices. 23-24, we scored the highest in the region for our maturity view. So we scored a 38 out of 55, which was the highest, which we were quite proud of. And we've recently just won the first Brilliant Award for our SMI physical health team. In terms of figures, year one, we achieved 20% of those. Year two, after starting, it was 34%. Year three, 47%, and year four, 67%. So even though obviously the ICB shared the figures where we are now, it's around the 50% margin. That's very much in line with where we were last year, and are tracking to exceed the 60% target set by NHS England. And obviously our main goal is to get to 75%. And it's something we continue to strive for and work to.
Thank you. You've been very busy. What about the effects of alcohol abuse and drugs? And does that come under are you looking at that as well?
It is also one of the core 6 checks that we work with people. One of the questions we ask is around their alcohol intake and their smoking intake. So we have very close links with SRP and work with them very closely through the Rough Sleeper programme and reset, but also through secondary mental health services in the SMI clinic. We have a monthly operational group, and we have members from drug and alcohol services as well as the ICB, local authority, public health that attend that meeting. So it is very well rounded in terms of the offer from the whole county rather than just what MPFT is doing. It's very much a joint effort.
Thank you very much indeed. Paul, do you want to carry on?
It's up to you, Chair. Yeah, we've got a few more slides to go through, but if you're happy for us to carry on, we'll carry on. Or if you want to just, if we can take
it that time, but I'd like to give you the opportunity because it's important to you.
If you want to just try and do a quick summary of the SMIs before trying to flip through the rest of the slides.
Yeah, so in terms of the Rough Sleeper homeless support, again, that's for patients with an SMI, and we use a no wrong door approach and very much an assertive outreach model. I've got 4 clinicians that work across Shropshire and Telford. They also link in with the Reset project within Shropshire. the link there is obviously to address health inequalities through the link to the physical health pathway, through links to local authority housing, through the ARC, reset, SRP, etc. We are looking, hopefully, we're wanting to look at supporting this group receiving their flu and COVID vaccines, ensuring physical health monitoring again, and using our SMI nurses. We're also working to reduce numbers presenting to A&E with mental health needs, but we are aware that not all attendance to A&E is due to mental health needs with these cohorts. Sometimes it is around that warmth and that belonging and that just feeling wanted. As I say, we work closely with a variety of different agencies, including Axis, Housing, Local Authority and the ARC. We work also closely with the police and want to increase their knowledge and education around working with this client group, and continue to work alongside obviously the local authority and further plans of an assessment centre to help with the rustling.
A lot of agencies. Do you monitor the effectiveness of your intervention with them?
Yes, yeah. So we are members of multiple different forums, operational groups, where we obviously provide data to the ICB. We ourselves obviously look at our figures, our numbers, how many people we're working with, and what the success rate is, so how many appointments. We work with someone called Enable as well that help people get back into employment. So we're able to identify actually how many people have been able to get back into employment. And through our SMI, we're also able to identify those people that actually have come into us initially with quite poor physical health, but actually through our monitoring and interventions, we've actually started to see a bit of a shift. An example being, there was a gentleman who started out on antipsychotics as an inpatient. He had unfortunately put weight on, which is quite common with antipsychotic. He joined the tennis, was on the border of going on to cholesterol statins. He attends the tennis weekly and has done so for over 12 months now. He's lost weight and he's no longer a candidate for statins. So it shows that it does work. Obviously, it's a generational thing, but we're just now, we're wanting to make the difference. And obviously that's why we're putting in the work that we are to do that.
Good, thank you very much indeed. Paul.
Thank you very much for that, Claire. I'm going to suggest we don't run through the rest of the slides that are out there for members, presumably, and happy to pick up any questions subsequently, but I just wanted to leave the last few minutes if you wanted there for any other questions or any
that's
other
fine. That's fine. Thank you. That's good of you. Thank you very much indeed. Tracy, do you still want to ask a question?
I think at the moment it's gone actually was around farmers and suicide, so I can ping a message.
Okay.
But I would like to just say something about the physical health clinics. I probably should say that I am actually a nurse GP practice in Ludlow. We run these clinics which are actually fantastic, and we do the fingerprint.
Can you use your microphone?
Oh, sorry, I've been private conversation. And we do the fingerprints, but we do ECGs, blood pressure, the whole shebang. But I can have 6 patients booked in and perhaps 1 will attend. And this is my real, because you've got your fantastic specialist down in the other part of the building who's waiting to see these people. We can't get them in, and it's not through not reminding them, because our particular practice keeps sending letters that reminds them, send them a text say your appointment is today. The ones we do get in absolutely love it, and they think it's fantastic because they're having all this care. So they're having half an hour with myself or someone else, and then they're going for another half an hour and they think that's wonderful. But we're not getting them in, even with all that reminding them. And I just wondered, is there anything else we can be doing to try and get them through the door?
We've recently obviously had some funding from the ICB to provide an outreach service. So we are now setting up the outreach pathway, and we've started to look at our DNAs. The SMI nurses in the clinics are also identifying their DNAs, so they are also starting out to go out now to those people that aren't attending, using our digital equipment to be able to do that at the home. So yeah, it's something we're working at the moment. We recognise it's a difficult, it's really difficult. But thank you for your comments.
Thank you, Paul.
Yeah, just on that point, actually, 4 other slides that I would have gone on to talk about were focused on what's being called intensive and assertive community treatment. It used to be a model of care known as assertive outreach services a while back. And there is a drive. There was quite a high profile series of homicides in Nottinghamshire last year, summertime, I think, that have led to a massive review by the Care Quality Commission in NHS England of exactly the group of people you're talking about, really, people who fall through the cracks of the of services, the people who get forgotten about, the people who you just stop noticing for a variety of reasons. So we're actively working with the ICB and others to think about what our strategy locally needs to be so that we can actually start to in-reach more proactively with that group of people, help them get to the things they need to get to, keep them engaged in services. So that's in the article.
Thank you. Ed, do you still want to ask a question?
Well, just very quickly, but again, I think a bit this time has run out, and I'm just wondering if there's a need for us to meet again to further this conversation, because I don't think we've really fully explored it all. But my question related to it's picking up something that Heather's mentioned and others have mentioned around the table, and resources with what Gordon was saying. And I wanted to know how you identified and monitored which geographical locations are connected with people who are feeling suicidal. I've seen no map of Shropshire, not that I want to see one particularly, but where these take place, or even a map to say where there's conversations taking place that might lead to that. I do realise that there will be clusters probably where there's the highest population, but I am interested in the rurality, and I am interested in seeing how far that goes out into the county extremities really as well. So it's that I would want to talk about. And we understand that in other local authorities, targeted signage is used at these locations to signpost people to support. And is this something we do in Shropshire? I've heard a lot about signage just now, so I am confident to some extent by that. But I also, what Councillor Bentic said, do we know about the success of this signage? And that's the sort of thing we want to hear about as well. Thank you.
Yeah, I agree. There's lots of things that we're not able to monitor how it progresses and the benefits of it. I think that's a fair comment in that, Gordon. Is that true?
Yeah, in terms of monitoring the outcomes of interventions, was that the question? Sorry. Yeah, yes. And it's always that age-old question, isn't it? Is how you demonstrate prevention, and again, it's looking at well, there's a few different ways you can do it, but one of the ways that we are exploring for the interventions we're looking at is what has the data shown prior to this intervention being introduced, and what could have been the likely trajectory had this have not, compared to what we're seeing now. Of course, there's a number of caveats to that. There's no simple answer for a prevention intervention. But absolutely, these are things that we are continuing to have conversations with the action group and other partners as to how we can best demonstrate return on investment, both in terms of finance and resource. Is this having the impact that we anticipate it would?
Yes, thank you. But I think the early part of my question is where I was really going is I haven't seen anything showing like a scattergram of where these things take place within Shropshire. And if there's a part that doesn't have these things taking place, what are they doing that's good that stops it helping elsewhere? Okay. Yeah, so as part of the audit, we have tracked postcodes. So this is specific to suicide deaths. However, at the moment, is exactly as you say, it's based on numbers, and as you would expect, the higher numbers are in the more populated areas. So one of the ways we're looking at this, we're not quite there yet, is looking at rates and how do those rates compare. So how many people live in that area compared to the numbers, and is that something, even though it is small numbers, which we know when we're looking at small numbers, one change, like one person either way, can have a massive impact. So it all has to be taken into account together, not just rates, not just numbers, but a fuller dialogue that's needed around that. So yes, that is something that we're still looking at, but we haven't presented it today just because it is small numbers and we wouldn't want to give, shall we say, information that could be interpreted in the wrong way. Yes, good. I appreciate that fully. I think we all do, actually. Thank you. But I do think some sort of mapping exercise for us. So when you've done it and got all the balances and checks in. But that would help us in where resources should be focused, and also it might even give us some encouragement as to where we're doing things right.
Okay, thank you.
Thank you. We do have lots of other questions.
We've got to go.
Okay.
Can I just?
Very quickly now.
Yeah, we're in the collective budget meeting.
All right. Okay. Sorry. Yeah.
So actually, one of my questions was, do you have access issues if you're doing stuff in the dome in Shrewsbury, and it's patchy everywhere else, and you talk about outreach, but that's quite intensive in resources. So what do you do about access to bring people into Shrewsbury, or are you only delivering for those people living in Shrewsbury?
So SMI Physical Health, we deliver it across the whole of Shropshire, Telford and Wrekin.
Yeah,
we're in every single GP practice. So in terms, every single GP practice we feed into, yes.
And mine across the border? No.
Not across the border, no. But we are in those that are within our ICB and our Shropshire, Telford and Wrekin geography. So yeah, we are in 52 practices.
Great. Good, thank you. Can I suggest that I'm sure you'll be agreeable if we list all our outstanding questions. I know Jeff wants to ask some stuff and so on. Peggy wants to ask some questions and send them on to you. Are we able to have a response that we can share with the committee? Good. Thank you. Is that okay with everyone? Good. Thank you very much indeed. Let's move on then to item 8, updates on the actions for the rural proofing and health care report.
Thank you, Chair. I'll keep this very brief, I think, and I'm happy to send a kind of written update around. Obviously, we said when we've back regularly to this meeting, that we would keep a monitor on actions. I think at the last meeting we reported certainly the use of the rural proofing toolkit. That I know now has been presented widely to partners, including the ICB and the partners, that we are now also going to be promoting that with marches, which is one of the things to do further action, and explaining about the work that was done with the committee, the rural proofing toolkit, and give examples of how we've used that. And one of the examples we have used that, and we do use it, is within the health team. So we've taken the rural proofing toolkit, there's an element around public health, and assessed ourselves against that. That's certainly one of the reasons that we continue to push for the outreach team, the farming work and others, because of it. Within that, it recognises the importance of some of that outreach into our more rural communities and make sure we have services accessible. So that's one of the ways that we are using, and we've continued to take the work forward. The impact of digitalisation, just to update, that we suggested that would be shared with the Digital Inclusion Network, who meet regularly. We have shared that, and that's been requested to board chairs in terms of looking at the impact of digitalisation and understanding which community groups are affected. Healthwatch and others have done some work on this previously. Again, so it's making sure that we monitor that. I think the other areas, as I said, we're focused particularly on communicating, and I know others have been communicating the importance of the work that was done by the Task and Finish group with partners. And as I've just alluded to, we will continue to take that forward, and personally will be taking thanks to Sophie for some support around that. I'll be taking through the work that you've done and the toolkit to them, not just to share that more widely across those partners. I'm happy to provide feedback once we've had that, but I've flagged it, shared it, and certainly initially that was people were really interested in that, but I'll do a more detailed presentation. So just to say that the work that came out of the rural proofing absolutely remains kind of upmost in our minds in terms of climate services and provision, and some examples of where that's been taken forward. I'll keep that updated.
Thank you very much. That's good to hear, because that was a rural proofing is a good report, and we really wanted it to be adopted and used. So I'm grateful that we continue to monitor its use. Do you want to say anything more about the Health and Wellbeing Board at the moment?
Thank you. Just to say, I'll get the right agenda this time. The Health and Wellbeing Board happened on Thursday. I know a number of members were at that board. It went online because of weather, so all the decisions haven't been ratified. They'll be ratified at the next meeting. But there was a focus on digital health and wellbeing. It was really helpful. We had a presentation from a number of partners, including the Digital Exclusion Network, the Digital Skills Programme, which again is working across the county to try and improve access for those who are not able to access digitally. And then there was an update from the ICS in terms of their digital strategy and some of the work that's going on there, and opportunities to join that work up a little bit more closely, make sure it's all aligned with in the county. And again, issues of rurality, access to digital technologies and services was flagged and raised and discussed. So there's a big focus on that. The other areas that we discussed in the meeting, we start to see some progress updates on the healthy weight strategy, some of the trauma-informed updates that have been the health and wellbeing board are pushing forward on, with probably the main areas of focus apart from that, and the pharmacy needs assessment work, which I know members of this committee have been interested in, that will be starting the update of the pharmacy needs assessment strategy in the coming months. So just to flag that.
Good, thank you. A lot going on there as well. Thank you very much indeed. Item 11, work programme. Oh, sorry, item 10, update on the joint health overview committee.
Again, conscious of time, I'll keep this high level and can provide further information if any members require it. So since the last joint HOSC meeting of the public committee in August, the committee has been focused, as agreed, on the outcomes of the staff overview, staff CQC report even, and focused on the must-dos and should-dos which were stipulated within that report. Working group has been getting underway with the ICB and staff colleagues as well, as was agreed in that public meeting, and has been also working with West Midlands Ambulance Service with support from Public Health to understand about what work has been done in terms of excess mortality within the Shropshire Telford and Wrekin system. So from this work that's been carried out between August and this date, the next meeting in public is planned to be for mid-December, with the date to be confirmed, and the focus of that will be to invite officers from across the integrated care system to attend, so that they're able to be further scrutiny on the outcomes of the must and should do's, specifically stipulated around the urgent and emergency care aspects of the CQC report, and also then looking at a separate item of winter preparedness as well.
Thank you very much indeed. Dated next meeting, item 12. Oh, sorry, it's been a long day. Item 11, work programme.
So just from today's conversations, the planned focus for the next meeting in January had been the local care programme. However, given that the committee's focus has been on adult mental health, and I think general sort of consensus that time has got away and that there was potentially more aspects to look at from this topic, that the committee may wish to revisit that, and perhaps assign adult mental health as that topic focus again in January. Also then that you'll be getting quickly close to entering the pre-election period, so that will likely be the last meeting of the committee for the municipal year, and that again a focus might be then for considering what the committee would want to recommend to take forward into the next council. Just from today's conversations, because the people committee have also attended to be involved in this work because of that joint focus of adult mental health, just to flag today that might be some considerations that members want to take back and add to their own work programme in that same way going forward, and also just flagging that discussion around children and young people's mental health, which has been a focus for the people committee, and there are plans for there to be a briefing in the new year on that, to have the update from what you heard in your committee earlier in the year as well.
Good, thank you. I'll get it right this time. Item 12, dated next meeting is going to be Monday the 27th of January 2025. Have a nice Christmas. And as we said, we will be sending the questions that are outstanding to you. And if we do look at this topic again in January, we hopefully have the benefit of what's happening with winter planning, what's gone on seasonally. Finally worth it. Oh, crikey.
It was just a clarification, but you started off saying, Chair, that you wanted us to be able to answer the questions that the committee had got because we hadn't had the time, and then we've moved on to have a conversation about.
Do you want us to bring the answers to those questions to the next session, or is it about answering those questions and also coming to the next session?
I would think I prefer a response to those questions by email or whatever, and then we can consider what we bring into the next session.
Yeah, whatever works for the committee.
Thank you. Can I thank you all for coming? And I think it has been a long meeting. There's so much to cover and so many different aspects, and we did some very good presentation. You did some very good presentation, so thank you very much indeed. It was very helpful. Thank you.
No.